Hi, I'm Dr. Joseph Wittering, and today I want to talk about the management of severe neurological pain with protracted withdrawal. So, the type of pain people typically feel with this injury is it can be electric shooting sensations through their body, it can be maybe just electric shooting sensations in their legs. Some people will report a lot of pain around their diaphragm, when they're trying to, it feels like there's some kind of ripping or tearing right underneath their skin there. I consider all of this to be neurological pain, neuropathic pain. And I'm going to explain my general approach in treating this with my patients. So the first thing that I usually do is I look at the other medications that they're on. So if a patient is on, say, a stimulating medication, maybe something like Wellbutrin or a more stimulating antidepressant, I may try reducing that. My experience doing this is that it tends to improve the pain. And so I'll also look at perhaps other medications that may be on, which can have side effect profiles that may aggravate neuropathic pain. And I'm thinking stimulant type medications. And so typically I'll start lowering the dose or removing those medications if it's possible. The next thing that I do is I might just have a patient wait, and we may not do any kind of treatment. So the pain can present in different ways in this population. Some patients will have this kind of waves and windows type pain where they'll have kind of manageable pain for about 4 months, and then they'll have like a 2-month period where they're in significant pain. With those patients, what I've from my experience working with them over time is that it's usually just better to kind of wait it out. And I've learned this because people, when I try and treat this, this pain in that 2-month period, the folks with the benzodiazepine withdrawal injury, they don't respond to medications as consistently as other patients with neuropathic pain. Either they'll have like strong, GI reactions to it, or it might even make the pain worse. And so there's always this unpredictability when you're treating, when you're introducing medications for these patients. And usually me and the patient together, eventually we just decide, you know what, I don't really want to risk it, so I'm just going to just wait it out. The next thing I do after that, and this is if a patient doesn't really have have one of those courses of the waves and the windows. We have some patients where they're just in pain for the majority of the time. They might just be in significant neurological pain for months on end, and then maybe they get a day or two of relief. With those individuals, especially if it's debilitating and they're not really able to do much, we typically just go with traditional managements for neuropathic pain. We try things like gabapentin, we try things like Lyrica, we may try amitriptyline. After we try those medications, if they don't work, we may try more unusual treatments for neuropathic pain. And these are, they have some evidence, and this can be things like Depakote, it can be things like lithium as well, things like verapamil. These are some of the treatments used for migraines. And we'll experiment with those medications, and we'll see if we can get the pain down to a level where it's manageable. So what do we do if those interventions don't work? That's when we kind of go to this next category of more dangerous medications. And we have had some patients where their pain is so significant that they're losing weight. They cannot eat because there's so much pain. They have no quality of life. They kind of stay in bed all day. And these are usually patients who, we've tried the other medications. I've sent them to tertiary specialist centers to go and meet with pain management doctors, and they haven't really had good outcomes. And so with these individuals, we'll try things like opiate pain medications. We may try things like OxyContin. We may try things like fentanyl patches. And we'll just very cautiously use these medications to get the pain down to a level where someone is able to eat again, so they can nourish their body and it can facilitate their recovery. Obviously, the big problem with this is a lot of these patients are still on benzodiazepine medications, and there's this interaction between opiates and benzos where you can cause some respiratory depression, which can be life-threatening. So with these individuals, we recommend that they pick up some Narcan from the pharmacy as well. We'll write scripts for that, and we'll also counsel their families to closely watch out for respiratory depression. It's never great, introducing a new medication for pain management that can be dangerous, like an opiate, but in some cases it makes sense, and they do carry an indication for chronic intractable pain, and so I believe it's justified to use it in those patients. So this is my overall approach to treating the severe pain in this population. Let me know if I missed something. If there's something that you found that's been really helpful for treating your neuropathic pain, and I didn't mention it, I'd love to hear about it in the comments below. So thanks for your attention, and I hope this video is helpful.